Merci beaucoup, William. Et on passe la dernière. Last but not least.
Thank you very much, William. Last but not least, Erika Loir, who's going to introduce to us the last clinical case to the panel with an interesting discussion following it.
Donc, merci de m'avoir permis de présenter ce cas aujourd'hui.
Many thanks for this opportunity to present this clinical case. The case I'm about to present, well, this is a story of Mrs. M, 64 years old. Main history, Sharp syndrome, followed up on for 20 years, pure articuliform, she never smoked. So treatment, hydroxychloroquine, prednisone, clinically speaking, multiple inflammatory bone pains. A general condition is altered. The clinical examination is normal, and the GP performs a scan in May 2005, which shows a pulmonary nodule of the middle lobe, as well as multiple osteolytic lesions. The exams are performed. Fibroscopy shows an adenocarcinoma with an EGFR mutation, deletion 19. Biology, hypercalcemia, a PET scan is performed. No secondary brain lesions, but there's a C3 lesion with a recession of the posterior wall, as well as an epidural, a threatening epidural. So this means initial management is urgent. Corticosteroid therapy, 1 milligram per kilo, biphosphonates, a step 3 analgesic by mouth. From a clinical point of view, the patient continues to suffer from debilitating pain, major functional impairment in terms of the right knee and the left tibia. So the bone mets meant that she had to go to hospital. She needed analgesics, including patient-controlled analgesia, a fentanyl patch, fentanyl interdoses sublingually plus paracetamol, pregabalin, etc., etc. So first line of treatment, erlotinib, 150 milligram per day. That's the standard dose, plus biphosphonates. The patient was assessed at 2 weeks and at 4 weeks. Safety is good, tolerance is good, no constipation under morphines, and also clinical gain. The pains have improved in terms of the lower limbs. At day 30, the additional radiation therapy begins after the C3 surgical wound has healed, so 30 grays for 10 sessions, over 10 sessions. So at the beginning, erlotinib, day 1, radiation therapy starts at day 30, and this is what emerged around day 45. The consultation begins, and we find a grade 2 mucositis. So we discontinue erlotinib. We see the patient 1 week later, and then we find that the mucositis has gotten worse, grade 3. So ulcers, dysphagia, dysphonia, fever. Her general condition is as altered and also severe undernutrition in the last month. Over the last month, she lost 5% of her body weight. Albumin dropped to 21 grams per DL. So we hospitalized the patient. We wondered how come she developed such toxicity. The radiation therapy, the erlotinib, and also the combination of both seems to be the culprit. So radiation inflammation of the esophagus, acute toxicity starts at 20 or 30 gray, and that's the case here. The radiation field clearly shows that this matches the toxicity, and also literature shows that this is a standard toxicity effect of radiation therapy in 0.5% of cases. It's a TAP, thorax, abdomen, pelvis CT scan. So a conventional effect. Erlotinib also causes stomatitis, grade 1 or 2 stomatitis, as opposed to such a huge mucositis. Our lab did an assay for erlotinib, and the plasma concentration was high, in excess of 3,000 at day 15 and day 30. So the therapeutic target ranges between 1,200 and 2,000 nanograms per mil. So in terms of pharmacokinetics, the balanced concentration for phase 1 is 1,200 nanogram per milliliter, and there seems to be a relationship between the plasma doses and also toxicity. There's a cutaneous rash, but no relationship in terms of diarrhea or mucositis. No drug-drug interaction. So the standard dose, 150 milligram, there was no drug-drug interaction that could explain such a high dosage. So in this patient history, what do we find? A combination of the two. No data from patient cohorts using a radiation therapy protocol that combines both spinal radiation plus erlotinib. So if we look at the preclinical data, erlotinib has a radiosensitizing impact. So there seems to be an impact. In other words, the number of cells is reduced in phase S. The cell cycle is altered, amongst other things. That would be one of the mechanisms. The number of cells in phase S is reduced. It is the most radio-resistant phase. So this radiosensitizing impact has already been observed to look at efficacy. For whole brain radiation therapy, there is efficacy data that shows that when you combine the two, it's a phase 2 trial on survival. So the level of, in terms of safety, we found there's radiation-induced interstitial pneumopathy. So we got 3 cases, 3 grade 5 cases out of 24 patients in Zhuang's study. That is one study, one cohort, 24 patients who received thoracic radiation. So 3 people died of interstitial pneumopathy. And there are other studies underway that I found, and that look at the combination between radiochemotherapy, radiation chemotherapy, and erlotinib. So some phase 1 trials show that in order to avoid grade 3 or 4 over-toxicity, erlotinib at the dose of 50 milligram per day, there is no over-toxicity. But at a dose of 100 or 150 milligram, there is over-toxicity. The other phase 1 trial showed that there is a fractionation change in terms of radiation therapy, with fractions of 0.4 gray per fraction, so huge hyperfractionation. So getting back to our patient, we managed her mucositis. So using sodium bicarbonate mouthwash, we continued the corticosteroids. We used the step 3 analgesic. There were huge erythematous lesions, so we used the antifungal agents. From a nutritional point of view, things were tougher. Very quickly, the patient met with the dietitians, but even though we enriched the diet and we increased her food intake, because the targets based on the SFNEP recommendations, the recommendation is between 1,600 and 1,850 kilocalories per day and 36 grams of protein. So she managed to improve her weight, but she was still bedridden and undernourished. So what else? We resumed erlotinib once toxicity dropped. We resumed it at a dose of 75 milligram per day. At 30 days, we found that erlotinib was well tolerated. The erlotinib concentration was slightly under the upper limit, but cachexia continued, alteration continued, and there was a major bone progression, also problems with the liver and the brain, probable carcinomatous meningitis. So we transferred her to a palliative care unit. This shows how toxicity can be potentiated by a combination between radiation therapy and erlotinib. Now the question is, dosing targeted therapy could probably help us manage toxicity. That's the question we're asking ourselves, but has yet to be determined. Thank you. Could this lady speak any faster? My goodness.
I feel the presentation brings up many points. I think that the pharmacokinetics of erlotinib and all of the tyrosine kinase inhibitors are not entirely clear. Indeed, for toxic levels, that's one thing, but for therapeutic levels, it's another. And many people have argued that extremely low doses of many of these agents may be quite therapeutic. And many people that I know, many oncologists, For older patients, never start the patients at 150. I personally have several patients who have responded very well to 37 milligrams and have continued to do so. The cautionary note could be, did you really need the radiation therapy to be added if she were responding? I think would be there. People have looked at the difference in patients who are progressing on erlotinib or gefitinib in the brain, but not in the rest of the body. This patient that you have was progressing everywhere. And that is perhaps where, if on rebiopsy earlier on, not including the brain, one might argue for the newer agents that affect the major resistance pathway of T790M, which may or may not have been an interesting area. The other aspect of those newer agents is that since they have less of an effect on the wild type EGFR, they may have fewer toxicities as such. So these are all challenges that could be included. So those are my comments. Other comments, Jeff or Pere?
Well, I'm surrounded by lung specialists here, so I'm going to be a low profile. But I have just two comments. One is that why the concentration of erlotinib was so high in this person? I mean, had any renal impairment? This lady has a background of inflammation and probably got many anti-inflammatory ibuprofenos. Maybe this lady has some microscopic damage to the kidney, or I don't know. Why it goes so high, And then the other thing is that should we reduce the dose every time we give radiotherapy? And I'm going to go directly to you. You said that normally in your hospital, you give to elderly people reduction, like in this case. This lady is 64. Are you a teenager now? Are you a teenager?
I am a teenager myself, but
64 is old.
no one knows where the line should come, but the dosing of both gefitinib and erlotinib have been controversial from the very early days. And the question is, if someone really has the mutation, do you need the 150 dose for any age? Right. I'm just saying for older patients who may clear the drug more poorly, this would be so. But it is important, and it's interesting that I get the idea from your case that the toxicities did not begin until 6 weeks. Until the radiation was introduced, the patient had a full month without problems with cutaneous problems or diarrhea.
Maybe you get a tail, so that you never clear completely. You keep a tail and accumulating.
If the drug's accumulating, that may be the exact.
And then you're right. You're giving maybe too much of a dose.
So we do see older patients, whether it's 60 or 80, that do get this cachexia syndrome. They a lot of fatigue, a lot of weakness at higher doses. So they're so lower dose might be a consideration. I think as your review properly shows, we don't really know how to use these agents with radiation. And so in our center, we'll often try to interrupt the treatment during radiation if we really think radiation is necessary. With a cord lesion, we probably would have given radiation as well. In the brain, we'll very often treat patients that are not symptomatic and follow them along. What's clear in this patient is that you gave full dose and they still got progressive disease very quickly. So it does speak to the likelihood that there's some other resistance mechanism ongoing. So I don't. Did you have an opportunity to rebiopsy the patient at any time, or?
Non, on l'a pas rebiopsié, mais on a fait on a redemandé la mutation T790M, mais qui est encore en cours en fait. On n'a pas les résultats.
Yes, but we did look at the T700 mutation, but the jury's still out. We don't have the results yet.
So the other thing that's really changing this field are blood-based biomarkers. So I think we're gaining more experience with just drawing peripheral blood because it's so hard to get biopsies in real time, serially on patients. And the concordance between blood genomics and tissue, at least right now, seems to be very good, particularly for T790M.
Liquid biopsies?
Yeah, just liquid biopsy, right? Draw a tube of blood and mail it off and get a result back.
And cheap.
And relatively cheap.
But the other aspect, if you see the mutation, then it seems to be real in the blood. If you don't see it, there still may be such a mutation. but or a different pathway, of course.
Yeah, but could be. There's what Jeff said. You can maybe get another mutation in the blood. Tell you the whole disease has changed over time.
No. What I'm referring to is that so far the liquid-based, the blood and even urine, seem to be very sensitive, but not as specific as the tissue. So far. But this again shows an area that we'll be going in. I guess my main thought would be, I guess the way I might have treated this patient would have been to get the maximum effect for the erlotinib before considering doing radiation. And that I probably would have interrupted at that point the erlotinib. And there is debate as to whether you can interrupt the erlotinib or not. I think the more of the argument is on the fact that in fact you can, and that this flare phenomenon is quite rare.
You mentioned in the beginning that there was a mixed connective tissue disorder in this patient. Was that a red herring, or do you tie it to something? Donc, vous avez dit au départ qu'il y avait un syndrome de Sharp.
Oui.
Est-ce que
You talked about the Sharp syndrome. Is this a red herring, or is it really connected to what happened? In the case reports, in the literature, is there an autoimmune component in these patients or not? No. We looked at the autoimmune situation, but that proved negative. Now, I didn't necessarily want to connect that or tie that in with the Sharp syndrome, but that's also the reason why we performed more tests with this patient. What about patients who are reported? You also have a pharmacokinetic problem with erlotinib. Was there a better response? With increased toxicity or not? Because you used the cetuximab metaphor for the colorectal cancer. We were unable to show that by increasing toxicity there would be a better response from the tumor. Does literature show anything to that effect? No. Not to my knowledge. Thank you.
Case, we've had 4 extremely interesting and modern cases, all of which, unfortunately, the panel was unable to provide the answers to. Thank you very much.